First of all, I'd like to thank the organizing committee for inviting us. I'm here to represent also the Asia Pacific Society of Interventional Radiology. The president was supposed to be here, but last minute there was an urgent meeting with the ministry, and so he sent me, the Secretary General, to represent the society. And I'm glad to say that PAIRS will be represented at the Asia Pacific Society. The meeting is in May in Singapore, and I think the president of PAIRS will be there to lecture as well. So today, I hope to share with you our experiences of alcohol embolization in renal angiomyolipomas. The renal angiomyolipoma, as the name implies, has components of fat, blood vessels, and smooth muscle. It is a hematoma, it's not a cancer, and therefore it is benign. Some people choose to call it a choristoma, but whatever it is benign, and the propensity for malignant change is also very low. It is a very rare tumor, more common in females. Most of the time it's sporadic, but about a fifth of the time it's associated with tuberous sclerosis. And for those tumors that are associated with tuberous sclerosis, they tend to be multiple and bilateral. These patients often go unnoticed until they become symptomatic, and a lot of them have the so-called classical triad of flank pain, palpable mass, and hematuria. And up to about 15% of them actually present with rupture of the tumor with retroperitoneal hemorrhage, as shown in these two cases. And they can be very bad bleed, such that they are in shock. And typically for those tumors that rupture, they are greater than 4 cm in size. This is a meta-analysis of a few publications in the early days, essentially trying to show the relationship of size and symptoms. And if you can see from this table that the bigger the size, and in here the cutoff is 4 cm, the chances of them requiring intervention is higher, and the chances of them being symptomatic is also higher. And hence, this is essentially the landmark paper to say that if the tumor has reached 4 cm, we should treat the tumor, even if they are asymptomatic. The diagnosis of the tumor relies on demonstrating fat within the lesion, and in that regard, CT and MRI is probably the best modality. So this is the typical hyperechoic appearances on ultrasound. And MRI, of course, it will be bright on both the T1 and T2 sequences. I think the main problem with this tumor is the differential diagnosis, and oftentimes, if there is very little fat content, it can be difficult to differentiate from renal cell carcinoma. And as mentioned earlier, if they have multiple renal angiomyolipomas, we have to screen the patient for tuberous sclerosis. The indications for treatment is quite straightforward. If they are symptomatic, regardless of size, and if they are asymptomatic, we only treat if they are more than 4 cm. Or the other less common indication is if you are uncertain whether it's malignant, this is probably prudent to treat. And in this instance, it's usually surgical treatment. So the treatment options include surgery. If they are small, you can just enucleate it. Slightly bigger, you need to do a partial nephrectomy or even a total nephrectomy. Transcatheter embolization is probably the mainstay of treatment, and this offers the best opportunity to preserve normal parenchyma. And this issue will become important in patients with a single kidney or in multiple tumors, because it's very difficult surgically to remove multiple tumors. So for asymptomatic tumors less than 4 cm, because of their propensity to cause symptoms and bleed, it is the current recommendation is to treat them. So if they are smaller than 4 cm, follow-up is sufficient. So in our hospital, we will usually require a cross-sectional imaging, usually CT, before we proceed to embolization. And typically, we would use microcatheter, and our embolic agent of choice is alcohol and mixed with lipiodol to opacify it so that we can see it during the treatment. For complex AML, we would supplement with other embolic agents like PVA particles, glue, and coils. As with all solid organ embolization, we will always give prophylactic antibiotics. Absolute alcohol is actually very toxic. It is very effective, but it's very toxic. And if we get into a non-target embolization kind of situation, it can cause a lot of damage. So to minimize this, we really need to be very super selective in our catheter location. Or in some centers, they would use an occlusion balloon to prevent reflux. And of course, by opacifying with Lipiodol, we can see it, and therefore it's safer. The thing about Lipiodol is that it does not dilute the concentration of the alcohol, so it is good to use. So just a few technical points. Whether it's 1:1 or 2:1 mixture, it really depends on how selective you are. If you are selective and confident that it will not reflux, then the amount of Lipiodol needed is less, so that you do not really need to see where you're going. But if your catheter position is precarious, you'll need more Lipiodol. But the downside of putting more Lipiodol is the amount of alcohol is reduced, or the amount of the mixture that you need to deliver will increase. We often use very small syringe to deliver, and we have to be very patient because the endpoint can suddenly come, the occlusion point, and if you persist, it will reflux. This is a typical example, fatty tumor on IVU, and CT clearly showing fat and a very vascular tumor. Angiographically, this is impossible to differentiate from RCC, and therefore you need the CT. And typically, we go very super selective, so in these instances, into 2 pedicles to release the alcohol-Lipiodol mixture. And at the end of it, you could see the Lipiodol staining. And this is what we want to see, complete devascularization of the tumor. And on follow-up, you can see very good result, and the effect is sustained over 3 years. This is another of our earlier examples. And you can see sometimes it can be difficult to tell which artery is supplying. So selective angiography is compulsory. And again, this is a good result with total devascularization. And again, very good results on follow-up, almost shrinking to nothing. This is a fairly complex looking AML. Again, one of our earlier cases. This one has some pseudoaneurysms within the tumor. Again, similarly embolized. For big tumors, it's not uncommon to use a lot of alcohol. And for this patient, the tumor shrink, but more importantly, what we call the angiomyopic component, which tend to be the one that cause rupture, is reduced after embolization. So for complex AML, we often need to have adjunct maneuvers. So in this example, there's a huge aneurysm within the tumor, and we had to use coils and even the unpluggable plug to help us embolize the aneurysm. Alcohol is actually quite toxic, and we usually limit ourselves to no more than 10 to 15 cc's if the tumor is big, and we often stage the treatment and do it over a few sessions. Just some examples. This patient in January 97 diagnosed angiomyolipoma. Because of the big size, we advised treatment, but patient refused. Presented half a year later with hemorrhage. And on the angiogram, you could see this is considered complex because of the aneurysm. Fortunately for her, by alcohol alone, we could obliterate this aneurysm. But just to be very sure, we put in coils as well. And this is the follow-up showing that the hematoma has resolved, but the tumor is still sizable. Another case, unusual tuberous sclerosis, in the sense that this is a male patient presented with gross hematuria, and you could see a very complex one as well, a big aneurysm within the tumor. Initially, we just injected thrombin, and then we alcohol the rest of the tumor. But the pseudoaneurysm opened up, and we had to inject glue. It's not very clearly shown here, but these are some of the glue casts, and added on a coil to make it more robust. Another patient, again, complex AML with large aneurysm within the tumor. In this particular case, very super selective kind of injection with glue first to obliterate the aneurysm, and the rest of the tumor with alcohol-Lipiodol mixture. So this is the final picture. And this is the pre-embo, post-embo, showed we successfully thrombosed the aneurysm, and over time the tumor has decreased in size as well. This is another case to illustrate the point that we should try to avoid using coils too proximally, because this will just shut off the front door. So in this patient, he was treated in another hospital and then subsequently became symptomatic again. And when we did angiogram, you could see that the original supply was totally obliterated and the capsular artery has hypertrophied to supply the tumor. So this was selectively cannulated and treated with alcohol lipidol mixture. As you can see, it's totally devascularized after that. But 4 years later, he presented with loin pain, and you could see that there is new bleeding in the tumor. And when we did the angiogram, actually the original vessels that we embolized were quite well occluded, and there's this new leash of vessel that seems to be supplying the tumor. The problem with this vessel is that we are not confident that this is purely supplying the tumor and not supplying, say, the bowel in the vicinity. So we did these are super selective injections. Even with super selective injection, we are not sure whether there is bowel supply. And therefore, we did the cone beam CT, which definitely confirmed that the vessel is supplying the tumor and there is no bowel supply. And with this added information, we confidently embolize this tumor. So the cone beam CT or even a hybrid angio CT system is very useful in this kind of situation. We published our experience a few years ago in the British Journal of Urology for over a 10-year period with 34 patients. And these are patients, about a quarter of them have tuberous sclerosis. About 40% of them presented with hemorrhage, but the bulk of the patients were performed because of size indication. There was one patient also with rapid growth. The volume of alcohol use is up to about 10 cc's. We staged the procedures in 8 patients. 32 of them have radiological follow-up. 2 were foreigners and therefore did not have follow-up. The average follow-up is almost 5 years. Technical success was 100%. Quite a few of them have post-embolization syndrome. We had one major complication due to non-target embolization, and this is the case of angiomyolipoma. The catheter position is actually very super selective, and yet there was reflux, and you could see that the alcohol, just a little bit of reflux, have managed to screw up quite a bit of the renal parenchyma. This is the pre-embo angiogram. Fortunately for the patient, there was only a transient decrease in the creatinine, but the renal function are normalized after a while. So with this cohort, out of the 14 patients hemorrhage, 13 were successfully arrested. 1 had persistent hematuria and had to go for partial nephrectomy. We had 1 patient with recurrent hemorrhage 8 years post-embo, and repeat embo was performed. 2 patients have nephrectomy because they increased in size during the follow-up, but both patients, the histology was not RCC. The majority of the patients treated have shown the size decrease on follow-up. So these are some of the tumors on follow-up showing the size increase over time. The interesting thing to note is that the increase is over a long period. It doesn't decrease in size and plateau off. We can't really explain why they behave like that. This is just a comparison of our data with what was published. Most are small case series, so ours is quite a sizable one, but the results are fairly typical. This one, they use coils and gel foam, so the embolization was not very distal, so the recurrent bleed is quite high. Just before I end, 2 more slides about what are the things that people are doing. So some group are using radiofrequency ablation to treat angiomyolipoma, but this technique seems to only work for a small lesion. As we said earlier, for tumors less than 4 cm, there's actually no need to treat them, so it's really controversial to treat the AML of this size. Some people have tried RFA of these lesions that is so big. I think they are mainly targeting the angiomyopic component rather than the fat. And it's still not clear whether this is beneficial. This is another interesting development. Sirolimus therapy has been shown to decrease the size of angiomyolipoma in tuberous sclerosis patients up to almost 50%. So if this is true, we may be out of business soon. So in conclusion, selective embolization of renal angiomyolipoma with alcohol is safe and usually well tolerated. It's effective in controlling acute hemorrhage, in preventing recurrent hemorrhage, and reducing tumor size. So I think for patients, and also for patients with tumor that is more than 4 cm, we should consider elective or prophylactic embolization. Before I end, just a little bit of advertisement. So as I mentioned earlier, the Asia-Pacific interventional meeting will be in Singapore in May. So we hope to see some of you there for the meeting. Thank you very much for your attention.